All right, let's talk about respiratory. So we're gonna start with respiratory today. Okay. I hope you guys can hear me and you guys can see the screen. If not, just send me a message and I'll look into it. All right, let's start with the first thing, which is your respiratory embryology. Okay, lung development. Okay, so let me get my pen here. So lung development occurs in 5 stages. So the way, let's just read first. Occurs in 5 stages. Begins with the formation of lung bud from distal end of the respiratory diverticulum during the week 4 development. Week 4 of development. So mnemonic is very high yield. So whenever the first stage has some mnemonic, just know that it is high yield. They don't put anything extra here. So this is high yield. So every pulmonologist can see alveoli. That's the mnemonic. Okay, so let's look into the details. So the first one we have is the embryonic stage, which occurs at the week 4 to 7. So now you have the pseudoglandular, which occurs 5 to 17, canalicular 16 to 25, secular 24 to birth, and alveolar 36 to 8. But how are we going to memorize that? This is too much, right? So the simple way now to memorize this all is to say that everything is occurring by 5 stages, meaning 5 weeks. So you always think about lung development as a 5-week thing. It's oh wait, you can't see the screen. Okay, now you can. So lung development is always a 5-week thing. So it's gonna occur somewhere 5 weeks. Okay, 4 weeks, great. The embryonic stage is gonna occur at your 5th week. Your pseudoglandular is gonna occur. So what I'm writing here is the max weeks you're gonna look at. So if they're saying 5 weeks or less than 5 weeks, you're gonna think about embryonic. If they're gonna say 15 weeks or less than 15 weeks, you're gonna think of pseudoglandular. If they're gonna say 25 weeks or less than 25 weeks, you're gonna look for canalicular. Or if they're gonna say 35 week, then you're going to look at secular, and you can just call it here 5 years, but it's already 8 years. So think about everything 5 with the lung development occurs in 5 stages, and the mnemonic is right here, which is every pulmonologist can see alveoli. Okay, and it occurs at the week 4 of development, or you can just think about 4 or 5, somewhere around that. Okay, now let's look at what each one of them are making quickly. So the first one we have is embryonic. So embryonic one, we have lung bud forms the trachea, forms the bronchial buds, forms the main stem bronchi, leads to secondary lobar bronchi, tertiary bronchi. So what do we see here? By week 5, you already have a tertiary segmental bronchi. So this is important. From lung bud, which was barely anything, if you look at the bottom, from here you already went into your terminal bronchi. This is all embryonic. Then you have second one, which is pseudoglandular. Pseudoglandular took all of those tubules and formed a terminal bronchioles. This is also important, terminal bronchioles. If you look here, so here are we at this level, terminal bronchioles. Now the canalicular takes those terminal bronchioles and forms the respiratory bronchioles, and they are right here. Secular takes those respiratory bronchioles, alveolar ducts, into forming terminal sacs, which are separated by primary septae. Okay, secular right here, they is going to form those primary terminal sacs, which are separated by primary septae. Second thing, for the last one, is the alveolar, which occurs right after birth till about 8 years. So this is way too many years, right? 8 years of after birth. So what are you making? Those terminal sacs are going to form adult alveoli. What's the difference between adult alveoli and your terminal sacs? Well, terminal sacs are separated by primary septae, while the adult one is separated by secondary septations. meaning they're going to further divide. If you look here, so those primary ones, they're going to further divide into more secondary. But important thing in the first one is all about your, what you have to just know this mnemonic right here, and you got to know the 5-week thing. Everything else is just read up material. Then the next topic we have is the choanal atresia. Choanal atresia is basically atresia. You already know what atresia is, a blockade, right? And what our choanal atresia means is the posterior nasal openings. And if you recall, you have anterior, superior, all those nasal septums. So the posterior one is the blocking here, right? Often associated with bony abnormalities or the midface. Most often unilateral, that's important. When bilateral represents an emergency and presents with upper respiratory tract, upper airway obstruction, noisy breathing, cyanosis that worsens during feeding, improves crying. This is important. Okay, and diagnosed by, this is also important. How would you diagnose it? By failure to pass nasogastric tube, and that could be confirmed with the CT scan. So now if you look into this and we say, what is the mnemonic on this one? Charge. Again, first stage rule, they don't write mnemonic unless it's important. So I guess this is important. Charge mnemonic, you have coloboma of the eye. What is coloboma of the eye? So you have eye, you have pupil here. It's just that pupil, it is open. So instead of having a full round pupil, you just have an opening. So the blackish line, it looks like this. It's like open. So that's called coloboma of the eye. Heart defects. The way I think about it is, as this is the face, right? Let's just draw the face. So you have a problem every single where. So you have eyes problem. You have ear problem. So look, I'm gonna make a tick mark. Eye problem, ear problem. Where is ear defect? Okay, ear problem. Now what else you have? Atresia of the cornea, face problem. What else you have? Face problem, restricted growth and development is total extra, and you have a heart problem, which is a main thing, and then you also have a genitourinary, so all GI and urinary defects. So you have all of these problems. Just it is associated with multiple malformation, right? So whenever you see choanal atresia, you will think about this charge syndrome, and yeah, that's pretty much high yield. Important thing in here again is recalling, it is a blockade of posterior nasal opening. You will not be able to pass the NG tube. You can see that on the CT scan, and there will be cyanosis that worsen with feeding, improve with crying. Those are the important things. Moving on with the next thing, which is called lung malformations. Lung malformations. So you have pulmonary hypoplasia. Okay, so what is a pulmonary hypoplasia? That one of the lungs, it is hypoplastic. Okay, so why? The question is why? Why did that happen? Well, that happened because if you have a congenital diaphragmatic hernia, usually on the left side. So let me draw lungs here. Let's say these are the lungs here, and this this side, the diaphragm goes up. You know, this side has the heart, right? So this, yeah. So this side, the diaphragm is going up. So now the diaphragm is just all in the lung. So what's going to happen to the lung? Lung is not going to form, man. It's going to be hypoplastic. That's what it is. Congenital diaphragmatic hernia, usually on the left side. Now the next thing is bilateral renagenesis is part of sequence. What is part of sequence again? Part of sequence is you're not going to form the lungs. Because you are going from what is the cause? Bilateral renal agenesis. One of the part of sequences, pulmonary hypoplasia, and we will do that in the renal. So these are two causes which causes pulmonary hypoplasia. Now, what is pulmonary hypoplasia? Well, it is a poorly developed bronchial tree with abnormal histology. Simple. The next one is bronchogenic cyst. Again, cyst, you already know it's some fluid-filled cavity cyst. Yeah, so let's see. It is caused by abnormal budding of the foregut and the dilation of the terminal or large bronchi. Discrete, round, sharp, defined, fluid-filled densities on the chest X-ray. And what is it going to look like? It's going to air-filled if infected. Simple. Generally asymptomatic but can drain poorly, leads to airway compression, recurrent respiratory infections. Um, so the easy way to think about it is as just say bronchioles. The mnemonic here is bronchioles, like bronchogenic, right? So bronchioles have cysts. That's the mnemonic. And when you think about bronchioles having cysts, you're going to say, okay, when you do the chest X-ray, you're going to see some fluid densities. Those are cysts, and these are lung malformation, meaning this is you will see in a child, in a newborn, coming in with a cyst, and you're going to say, oh wow, it's a bronchioles having a cyst, so bronchogenic cyst. Okay, that's all for this one. Moving on with the club cells. Oops. Wait, let me zoom in. Okay, club cells. Club cells are non-ciliated, low columnar, cuboidal, with secretory granules located in the bronchioles. They would do three things. One of the things they're doing, they're going to degrade the toxins via cytochrome P450. They're going to secrete the components of the surfactant. Third thing is the progenitor cells for club and ciliated cells. Now, important thing in this is if you look in the second one right here and the first one. So secrete the component of surfactant, okay? Because we all know that type 2 pneumocytes are the one doing two things, one of which is to secrete the surfactant. So, but this guy, club cell, is also secreting the component of surfactant, so important thing to keep in mind, okay? So, what is not here, which is also important, one of the cells that you will see is called goblet cells. So goblet cells. What are goblet cells? You already know. They secrete mucus, mucin, and that helps the mucociliary clearance. And we will read what is mucociliary clearance in the physiology. Where are they present? These goblet cells are going to be present proximal in the on the airway and not distally, and we will see how in physiology. So these are the club cells. Let's look at now the alveolar cell types. So we have two. Wait, here you go. Oops. Yeah, alveolar cell types. We have type 1 pneumocytes, type 2 pneumocytes. Type 1 pneumocytes are squamous. And let's take a look here. Type 1, they are squamous cells. They are 97% of the alveolar surface. They are thinly lined, the alveoli, picture A, for optimal gas exchange. And you can see all of the thing in the alveoli is type 1 pneumocyte. And you have, in these type pneumocytes, you have pores of Cohen. Pores of Cohen are anatomical communications between alveoli that allow for passing of air, fluid, phagocytes, and bacteria and pneumonia. So basically think about it as a gap junction sort of a thing. They allow everything here. If you look air, fluid, I mean, what's left, man? I mean, I don't see anything. So it's like pores of Cohen. What is it? It's gap junction. So I'm not saying it is gap junction, just to keep in head that there is something, okay? It is pores of Cohen. The second thing is type 2 pneumocytes. Well, this is important, right? Type 2 pneumocytes is important. Let's talk about it. So type 2 pneumocytes, they are cuboidal, clustered. They have two functions. They serve as a stem cell precursor for two cells, for type 1 and themselves type 2. They proliferate during the lung damage. So these are the stem cells. That's very high yield. If you have any damage to the lung, these are the ones which are rebuilding type 1 and themselves, as they are the stem cells. That's very important. Second thing, very high yield, they're going to secrete surfactant from laminar bodies. Arrowhead in B. Look at the laminar bodies right here. So these are the laminar bodies. Now, one of the things that you will see is, wait, let's just erase this. One of the things you will see is they will say, in the questions, they will say, you have a low laminar bodies count. So low laminar bodies count. So they want you to think, okay, if you have a low lamellar body count, you're going to have decreased surfactant. Why? Because surfactant is coming from these lamellar bodies, and if you have low lamellar bodies, you're not going to have surfactant. So in your, we will read this topic, which is called neonatal respiratory distress syndrome. So they will say, you have low lamellar bodies, a low lamellar body count, which will reflect again surfactant deficiency. That's one thing. Now, other thing is, these cells not only secrete surfactant, but they also store and secrete surfactant in the lamellar bodies. And now another thing they might ask you is how these look like on electron microscopy. So they will say on electron microscopy, granules containing parallel stack of membrane lamellae. Again, parallel stacks, if you zoom in here, you will see they will sort of contain a parallel stacks of lamellae within them, and those are your lamellar bodies. Okay, so yeah, that's about lamellar bodies. Let me erase the rest here. Okay, now let's look at this application of law of Laplace. Application of law of Laplace in the alveoli. Alveoli have increased tendency to collapse. Yes, on expiration as radius decreases, 100%. What is surfactant doing? Surfactant is a decrease in alveolar. Surfactant decreases alveolar surface tension, decreases alveolar collapse, decreases lung recoil, but increases the compliance. What is compliance? In simple words, compliance is distensibility. How distended can you be? How much your lung can have the capacity to distend itself? That is your compliance. So surfactant is increasing the compliance. It is composed of multiple lecithins, mainly dipalmitoyl phosphatidyl choline, DPPC. Which they haven't mentioned is one more thing, is it's called not only this, because they said mainly DPPC, right? But the other one they will also mention is called phosphatidyl glycerol. So phosphatidyl glycerol. This is also surfactant. So surfactant synthesis begins about 20 weeks of gestation and achieves mature level by 35 weeks of gestation. Great. And corticosteroids or glucocorticoids are important for fetal surfactant synthesis and lung development. Collapsing pressure equals 2, which is the surface tension divided by the radius. That's the collapsing pressure. So the whole hallmark here is type 2 doing two things and also secreting surfactant. There are two surfactants, DPPV and phosphatidyl glycerol. And yeah, pretty much that's what we have in type 2. Then the last one we have here is alveolar macrophages. They phagocytose the foreign material, release cytokine and alveolar proteases. High yield is this thing, hemosiderin-laden macrophages, which are found in pulmonary edema, alveolar hemorrhage, hemosiderin-laden macrophages. If you look at the picture, oh my bad, now you can see alveolar macrophage. Okay, if you look at this picture, you have type 1 pneumocytes, type 2 pneumocytes, alveolar macrophages scattered in capillaries. And that's all for that topic. Now we are looking at next one, which is your NRDS. Neonatal Respiratory Distress Syndrome. Okay, so here you all know we have surfactant deficiency, which will cause increase in surface tension, which will cause alveolar collapse, which is a ground glass, very high yield ground glass appearance on the of the lung fields. Right here, if you want to look, you can see some ground glass appearance of the lung fields. Highest yield are the risk factors, which are your prematurity, diabetes during the pregnancy, and that's going to cause increase in fetal insulin. And now you say, hey, how would fetal insulin cause NRDS? Well, when you have increase in fetal insulin, is going to cause inhibition of corticosteroids. Inhibition of corticosteroids production. And guess what? Who was producing the surfactant? If you go back here, it says right here that the glucocorticoids, they are important for fetal surfactant synthesis, right? And since you don't have that anymore because you have a lot of insulin in, because of diabetic mother, right? So now that insulin is going to hit your corticosteroid production, and hence you're going to go into NRDS. Okay. C-section, again, same sort of a thing. C-section is there is no stress. When there is no stress, there are no cortisol, no corticosteroids. So when there is again, my bad. They have written here. So decreased release of fetal glucocorticoids. Why? Because there is a less stressful than vaginal delivery, for sure, 100%. What else do we have? Treatment. Let's talk about treatment here. So a person has developed NRDS. What do we do? Maternal glucocorticoids before birth, or you can give exogenous surfactant to the infant. Therapeutic O2 can result in very high yield as rib. You give therapeutic O2 to an infant, and he or she is going to develop rib. What is rib? Retinopathy of prematurity, intraventricular hemorrhage, bronchopulmonary dysplasia. Rib. The ribs are going to go down. Retinopathy. And why? The question is how and why. Because this O2 is going to form free radicals. Free radical formation, that's one thing. Free radical formations. One. Second thing, what's going to happen is that this O2 is going to start forming neovascularizations in the retina, right? In retina, and that's going to develop retinal detachment, and that is going to develop blindness. And how would you have, they might ask you, why would you have neovascularization? Because it's going to increase the VEGF, vascular endothelial growth factor. So retinopathy of prematurity, high yield. Okay, on the right side, what do we have? Screening test for fetal lung maturity is one thing you can do is lecithin sphingomyelin ratio, LS ratio, in amniotic fluid. Greater than 2 is healthy. Less than 1.5 is predictive of NRDS, and you can see these ratios here. If your ratio is less than 1.5, below this, you're gonna think about NRDS. If it is above, you say healthy. Okay. Let me erase all this extra stuff that I did. Okay, so that's the first thing, right? Second thing, you can also look at your foam stability index. Third thing, you can look at your surfactant albumin ratio. But most important, the first one. Okay, persistently low O2 can cause risk of PDA, patent ductal, and we will see that in cardiology, how low O2 tension is going to cause PDA. Okay. So let's look at this graph now. In this graph, what do we see? We see LS ratio, lecithin sphingomyelin ratio. Yes. So if you look at the lecithins, it is look at this 30-week 30 gestation. What are we doing? The lecithin increases sharply, right? So and sphingomyelin just goes down, and it's gonna be, so the ratio that we calculated after this, it's gonna be more than 2, and we will call it healthy. And if it is less than 2, we would say it is an RDS. Now the question, one extra thing actually, is what is sphingomyelin? We did talk about lecithin, and if you go back here, we did talk about all these lecithins, DPP and phosphatidylglycerol. But what is sphingomyelin? Sphingomyelin, it is membrane phospholipid. It is membrane phospholipid. If those are surfactant, this is membrane phospholipid. Okay, yeah, that's pretty much it for NRDS. So one of the extra thing that you will see, which is not mentioned here, probably in the new, this is 2023 edition, by the way. So I don't know if the new one might have this or no, I don't know. But it's called surfactant. It's called PAP. What is PAP? PAP is pulmonary alveolar proteinosis. And what is this? So here we have surfactant deficiency, right? In NRDS. So in PAP, what are we gonna have? We have uh, impaired. So let me write it down. So what do we have here? We have impaired uh, clearance of surfactant from macrophages. So what's going to happen is you will have so much surfactant remaining in the lung. Well, there is no clearance. So what's going to happen is when you look at so they will say, okay, we did a pass stain, periodic acid sift stain, and it is positive, uh, and it found the material which forms lamellar bodies. Again, same thing, lamellar body. Whenever you think about lamellar body, think about surfactant, man. That's simple as that. And you will say, okay, because there are so much lamellar bodies, so much lamellar bodies, positive PES stain positive for lamellar bodies, and there is so much, you will say it's called PAP, pulmonary alveolar proteinosis. Okay, PAP. It is lipoproteinous material that is going to be PES positive. And what is lipoproteinous material? It is basically surfactant, a lot of surfactant. Why? Because you cannot clear it out. Okay, that's all for the PAP. And I guess that's all for the embryology. Now let's look at anatomy. Okay, let's see. So what do we have? Okay, respiratory tree. Give me 1 second. Okay, respiratory. We have the conducting zone and respiratory zone. Okay, conducting zone. If you look here in this image, you will see conducting zone is till the point of terminal bronchioles, and respiratory zone is till the point of alveolar sacs. So it only has two things: respiratory bronchiole and alveolar sac. So that's easy to remember. So let's look at what they are. So conducting zone is a large airway, consists of a nose, the pharynx, the larynx, the trachea, the bronchi. Airway resistance is highest in large to medium bronchiole, high yield point. Where is airway resistance highest? In large to medium bronchiole. Small airways consist of bronchioles that further divide into terminal bronchioles, which are large numbers in parallel, meaning least airway resistance. Okay, what are conducting zone doing? It warms, humidifies, filters air, but does not participate in gas exchange. It is also known as anatomical dead space. And what are I've seen something called what are the organ names which play a part in anatomical dead space? These right here: the nose, the pharynx, the larynx, trachea, bronchi. These are all anatomical dead spaces. Now, conducting zone has a cartilage and goblet cells which extend to the end of bronchi. Okay. Pseudostratified ciliated columnar epithelial cells primarily make up the epithelium of the bronchus and extend to the beginning of the terminal bronchiole, then transition to the cubital cell. What are they all doing? They are important clear mucus and debris from lungs. Very high yield at this point. Mucociliary escalator. Okay, they would clear the mucus and debris from lungs. Mucociliary escalator. And why am I saying that's important? Because something you will see, it's called alveolar. And we will read that and then I'll highlight it. Okay. Now, airway, smooth muscle cells extend to the terminal bronchioles, sparse beyond this point. So a lot of questions are going to come through this. So let's just take a look at this image and figure out what they are doing. So we said the bronchioles is highest resistance. Just write HR there. Highest resistance. Bronchioles. So the goblet cells, they will finish by this time. By bronchioles, they're gonna they're not in the proximal bronchioles. The goblet cells are gonna be there, and that's it. Not after this. Terminal bronchioles, you will start seeing club cells. Club cells. Okay, so 3 important points: bronchi, highest resistance; bronchioles, goblet cells; terminal bronchioles, club cells. Okay. in the respiratory, we'll read that respiratory first. But talking about mucociliary escalator. So what is mucociliary? Extra point. What is this? So mucociliary. So let me read this one out. So ciliated mucosal epithelium that starts from trachea to the proximal respiratory bronchioles. Mucus and trapped air particles within the mucus are constantly swept upwards toward the pharynx. The mucus debris are then swallowed, and it's called mucociliary escalator. So the whole point that I mentioned is about cilia. So all the mucus and debris that you get till this point, the cilia are gonna sweep up all that mucus, and you will swallow it or throw it out. And this is called mucociliary escalator. Okay, but what's gonna happen if something goes beyond this point? You know, not everything is gonna stay here. Not cilias are. Not everything gonna stay, right? So what's gonna happen beyond this point is called alveolar. Phagocytosis by the alveolar. So clearance. So there's a specific size, which is 2 microns actually. My bad, 2 microns. So let's read this one out. So clearance beyond this point into the respiratory bronchioles and alveolar sacs, they depend upon phagocytosis by the macrophages, alveolar macrophages. Either they would destroy them, or they would, if they're not, they would transport into. If they're not, they cannot destroy. They would transport to the pulmonary lymphatics or terminal. In the lymphatics, the immune system would start working and all that. But what is the size of this thing which can go beyond this respiratory zone? Is called 2 microns, less than 2 microns. So only finest particle less than 2 microns can travel into the respiratory bronchioles and alveolar, where they are phagocytosed by the alveolar macrophages. So that's pretty much it. And let's look at the other zone, which is called respiratory zone. So lung parenchyma consists of respiratory bronchiole, alveolar ducts, and alveoli. Participate in gas. Important thing is they would participate in gas exchange. Most are cuboidal cells in the respiratory bronchioles, and simple squamous cells up to the alveoli. Cilia would terminate in the respiratory bronchioles. Alveolar macrophages, this is the point. Alveolar macrophages clear the debris and participate in immune response. Okay. So here, this is all about mucociliary escalator, and all here is your alveolar macrophages clearance. And that's and one more high yield point, as we were mentioning, is this thing. Cilia would end at the respiratory bronchiole, and alveolar as well as alveolar macrophages will start here. So 2 important points. So just recalling the important points here. Bronchi, you have highest resistance. Bronchioles, you have goblet cells. Terminal bronchioles, you got club cells. Respiratory bronchioles, you're going to have cilia would end here, and alveolar macrophages will start. And that's it for that page. Moving on to the next one, we have lung anatomy. So right lung has 3 lobes, and you can see that in the picture right here. 1, 2, 3. And the left lung has 2 lobes, 1 and 2. So let's read. So right lung has 3 lobes, the left lung has 2 lobes, and the lingula, which is the homologue of the right middle lobe. Instead of the middle lobe, the left lung has a space occupied by the heart. Yes. As you can see right here, heart is there, you just got 2 lobes. And here you got 3 lobes. Okay. Now, in relation to the pulmonary artery to the bronchus at each lung hilum is described by rales. What is rales? Right anterior, left superior. Rales. Right anterior, left superior. Carina is posterior to the ascending aorta, and anterior medial to the descending aorta. And you can see what is carina is basically bifurcation of this trachea into 2 left and right bronchus is called carina. Then you have this right lung is more common site for inhaled a foreign body because the right main stem bronchus is wider. Important thing. Okay, let me highlight this. So it is wider. You can see it's big. Um, it is wider, more vertical, right? And it is shorter. You can see it is very short. So if you aspirate the peanut, where it's going to go? If you're supine, meaning if you are lying straight up, like your face is towards the sky and you're just lying down straight, it's called supine. So usually it enters the superior segment of the right lower lobe. So we just write here SRLL, right? While you're lying on the right side now, it's going to enter the right upper lobe. So we're going to write right upper lobe, right? And the last one, we're going to say if you're upright, meaning if you're just standing, it's going to enter right lower lobe. So what's the difference between these two? I mean, you can just say, even if you're laying down or you're just upright, it's almost the same thing, except that it's going to go into the superior segment, while this one is just going to go into anywhere in the right lower lobe. Okay. One extra thing they will ask you, which is not mentioned here, is about your prone position. So when they will say when you're prone, what is prone? You know, when you are lying on your chest, meaning your back is towards the sky, you're just on your chest. It's called prone position. Here you have, if you aspirate a peanut, where it's going to go? It's going to go into right middle lobe. So we have all the lobes affected. Lower lobes affected here, upper lobes here, and middle lobe right there in the prone position. Okay, that's what we have, and they were saying carina is anterior to carina is your anterior abdominal aorta, and posterior to carina is your descending aorta, and you can see that here. So now let's talk about your diaphragm structures. Diaphragm structures, simple but important. Structures that perforate the diaphragm are at T8, T10, and T12. Mnemonic is here. 8, 10, 12, right? For 8, you have 8 IVC. 10, you can see O here, right, with the esophagus. So 10 esophagus. 12 aorta, aortic hiatus, right? So that's what you have basically. Diaphragm is innervated by C3, very high yield, is the phrenic nerve. Diaphragm is also innervated by the phrenic nerve, which is the roots for the phrenic nerve are C3 to 5. Main pain from the diaphragm irritation can be referred to the shoulder and trapezius ridge, again shoulder C5 and trapezius ridge C3 to 4. Phrenic nerve injury can cause elevation of the ipsilateral hemidiaphragm on the X-ray. So again, this is important, that if you have a phrenic nerve injury, it's an ipsilateral hemidiaphragm elevation. Okay, so in other words, I would say that the elevation is going to occur on the same side as the injury. Okay, so if you have a left side injury, the left side is going to be up. Hemidiaphragm elevation, the left side is going to be up. So phrenic nerve is here. This is pretty high yield. C3, C5 phrenic nerve, and anything that irritates the phrenic nerve will you can have anything. You will see in GIT and how phrenic nerve can cause even in peritonitis. If you just recall your pancreas or your gallbladder, all those issues, the pain does go to the left shoulder. And why? Again, the same thing. Phrenic nerve gets irritated, and we will see that in GI. So phrenic nerve high yield, C3, C5, all of that. Hemidiaphragm ipsilateral high yield. The mnemonic they have is called I8, 10 eggs at 12. You can memorize it. It's I can't eat 8 eggs, so I don't know how that's gonna work out. But C3, C4 and 5 keeps the diaphragm at very high yield. C3, 4, 5 keeps the diaphragm alive. Other bifurcations are common carotid bifurcates at 4. So 4, 4, C4 common carotid 4, bifurcates at 4, tracheal bifurcates at T4, again T4 trachea, C4 common carotid, T for trachea, and abdominal aorta bifurcates at L4. The only thing that is new, which is not new without a mnemonic side of a thing, it's called abdominal aorta, which occurs at T4. C4 common carotid, T4 trachea, L4 abdominal aorta, and I think it's also in GI, so you'll see that over there as well. Okay, moving on with the respiratory physiology. Okay, what do we have? Lung volumes and capacities. High yield. Simple but high yield. So let's talk about it. So a capacity, important. A capacity is always a sum of two things, and a volume is just a single thing. There are 4 volumes for capacities. Tidal volume. It's also TV, right? Or VT, my bad. So tidal volume, VT. Tidal volume is your normal. Let's look at this image first, and then we'll read that. So this is your normal. Tidal volume is your normal breathing in, breathing out type of a thing, right? Breathe in, breathe out, breathe in, breathe out, normal. But as soon as you breathe in more than normal, that becomes your IRV. What is IRV? Your inspiratory reserve volume. IRV. Inspiratory reserve volume, right? IRV, yes. So this is all you can breathe in. This is the max you can breathe in. After this, you're like, I can't. This is the max I can go for. IRV. So VT, your normal breathing, while IRV, your maximum inhalation, deep inhalation. So, and what is ERV then? Again, IRV is inspiratory, ERV is expiratory. So expiratory, whatever the max you can breathe out, ERV, expiratory reserve volume. But again, if you look here, you can't really breathe out everything from the lung. There is something called RV. What is RV? Residual volume. RV. What is residual volume? That no matter what you do, you cannot take this air out of the lungs. So let's read this first. So air in the lung after maximal expiration. So you have maximally expired, but still you got the air here, and that is your RV. RV and any lung capacity that includes RV cannot be measured by spirometry. So yeah, I mean, you can't measure it because you can't take it out. How can you measure it? There's no point of measuring it. But now when we talk about total lung capacity, for sure we're going to look at the whole thing. For sure we're going to look at all and everything we can take in, even whatever we have as a residual volume. That's all called total. That's why the name is total lung capacity, right? And what is FRC? High yield. Let's look at FRC. Well, FRC is, read here, let's look. FRC, functional residual capacity. It is just two things. ERV, which it's your deep expiration. I mean, you want to expire the whole thing out. This is your maximum expiration, and your remaining, whatever left behind, RV, is called FRC. So volume of gas in the lungs after normal expiration, outward pulling force of the chest is balanced with the inward collapsing force on the lungs. And we will see that in the next page. What are they talking about here? It's more defined in the next page. So FRC, just know what FRC is, which is RV plus ERV. Simple. Now let's quickly look into this reading part. So tidal volume is air that moves into the lungs with each quiet inspiration, and it's right here with the quiet inspiration, expiration. That everything we're doing normal. This is VT, yeah, and it's about 500 ml. Inspiratory reserve volume. It's the still air that can still be breathed in after a normal inspiration. So right here, after a normal inspiration, you can still breathe in this much, and this is your IRV. ERV is something that you can still breathe out after your normal inspiration or normal your breathing. It's right here. And then you have the residual volume, meaning right here, which you cannot breathe out even if you maximally expire every year from the lung. is called residual volume. Inspiratory capacity is your IRV plus VT, meaning whatever you can breathe into the lung. So all of this, if you look here, all of this is your inspiratory capacity. FRC we already talked about, but again it's your ERV plus IRV. I mean ERV plus RV, and your vital capacity. Vital capacity is your VC, meaning whatever you can breathe in and breathe out, just that much of air. Whatever you can breathe in maximally and breathe that out maximally, that is your vital capacity. That's your lungs capacity, right? Maximum volume of the gas that can be expired after a maximal inspiration. The last one is total lung capacity, and we did talk about it. It's all of these joining together is TLC, volume of the gas present in the lungs after maximal inspiration. Okay, so that's pretty much it for that. And now let's talk about work of breathing. What is work of breathing? Well, work of breathing refers to the energy expended or O2 consumed by the respiratory muscles to produce the ventilation needed to meet the body metabolic demand. It compromises the work needed to overcome both elastic recoil, one thing, and the second thing is airway resistance, i.e. work equals force times distance equals pressure times volume. Now all of that is what are we trying to say here? Simple. Now this thing, next line, they're important. Minimize by optimizing respiratory rate and the VT. So we can minimize this work of breathing. So what is work of breathing in a nutshell? It is basically you maintain the VE. But to maintain VE. Okay, and we will see by how. And the question is by how? By optimizing or by increasing / decreasing RR, which is your respiratory rate, and your VT, your tidal volume. So now a pathology comes in, and then that's high yield, which is it would increase in your restricted lung diseases, right, and your obstructive lung diseases. But the things that are changed within each of them is different, meaning in your restrictive diseases, let's say RD, restricted RD, okay, in your increased RD. How? Because you are increasing the work to overcome the elastic recoil achieved by, how is it achieved? Increasing the RR, but decreasing the VT, which is the tidal volume. And again, go back there. What is tidal volume? Tidal volume right there, VT. It is your normal breathing. So in your restrictive diseases, you are decreasing the tidal volume but just increasing the respiratory rate, because you're restricted. Again, if you think about it, you can't push the air in. It's a restricted disease. So your VT is not going to be your 500 ml, which is your normal. So to compensate and to maintain your VE, now again, what is VE? What is VE? Okay, let's look at to maintain VE. It's a minute ventilation, and we will read this right here. It's called minute ventilation. So to maintain a minute ventilation, which is your VE, we have two factors to mess up with. One thing is RR, and second thing is VT. In simplistic words, in your restrictive diseases, you're increasing the RR but decreasing the VT, because how the restrictive disease occurs. That's how they do it, right? That's how what happens. The second thing is your obstructive diseases. In obstructive disease, if you look back here, you're decreasing the RR but increasing the VT, and this is because out of a high yield. So in obstructive disease, you're decreasing the RR but increasing the VT. So two different diseases, two different things. But overall, what are they trying to do to maintain VE? What is VE? It is your minute ventilation. What is minute ventilation? Is going to come up right now. So let's talk about minute ventilation and high yield. And this is all because this is very physiology, right? Normal physiology. And BME loves normal physiology. Okay, so let's look at VE now. So VE. Actually, let's just do VE first, and then we'll get back to the dead space. So this is your minute ventilation. This is VE, abbreviated as VE. Total volume of the lung entering, total volume of gas entering the lungs per minute, meaning whatever gas is going into the lungs, no matter it's going into the dead space, not dead space, wherever it's going into the lung. That means we're going to calculate that into VE, which is your minute ventilation. As the name suggests, minute, in 1 minute ventilation, how much you ventilated. Simple. How is it calculated? Again, VE equals VT times RR, and these are the exact parameters which are messed up in your obstructive diseases and restrictive diseases. So this is your minute ventilation. What is alveolar ventilation now? Alveolar, look at the wording, alveolar ventilation. Alveolar is simple as whatever is reaching alveoli each minute. That's your alveolar ventilation. And how can you know what is alveolar ventilation? Because you are going to subtract your dead space. And we will read that from back again, what is dead space and all that. But alveolar ventilation is whatever the volume of air is going into the lungs subtracted by the dead space is your alveolar ventilation. Normal values, let's look at that. RR, respiratory rate, normal is 12 to 20. VT is about 500. VD, again, is your physiological dead space, about 150. So let's look at physiological dead space. Again, VD, which is a physiological dead space, it equals VT, which is your tidal volume, times PaCO2 minus PeCO2 divided by PaO2. I mean, if you want to memorize it, go ahead, but let's read this one, which makes sense. So VD equals physiological dead space equals anatomical dead space of conducting airway plus. So anatomical dead plus alveolar dead space. So again, what is physiological dead space, anatomical dead space, and alveolar dead space? And what was anatomical dead space again? We recall from anatomy, the nose, the pharynx, the larynx, all of that, which the air does go through, but there is no gas exchange. And what is alveolar dead space now? Well, the alveolar dead space is right here. Apex of the healthy lung is largest contributor to the alveolar dead space. Why? Because in the apex, you're getting lots and lots of oxygen, meaning the air, but you're not getting the blood. So that's your that is going to be your alveolar dead space, because you're getting the oxygen, but there is no gas exchange. Guess what? It's an alveolar dead space. VD equals volume of inspired air that does not take part in the gas exchange, and we did talk about it like 10 times now, so we know what VD is. On the right side, it says physiological dead space is approximately equivalent to anatomical dead in a normal lung, maybe greater than anatomical dead in lung disease with ventilation perfusion mismatch. As a simple thing, what did we talk about here? VD is your physiological dead space, which equals anatomical plus alveolar dead space. Simple, nothing, no fancy things, simple. And minute ventilation, alveolar ventilation, we would subtract that we would subtract that physiological dead space, because we want to know where the gas is going in, how much gas is going into alveoli, not in the dead spaces. So we will subtract that physiological dead space, and that's how we're going to get the alveolar ventilation versus your minute ventilation. And this is very high yield points. Okay, guys, what I'm saying is very high yield. Lots of question and NBMEs on simple things. Minute ventilation is, and because we don't read it much, right? We look at hey, come on, it's minute ventilation. We are not here what is called the critical medicine doctors here, so we don't care. But this is simple, high yield things. Minute ventilation, simple. It is your whatever is going to the lung. Alveolar is you gotta subtract one thing only, which is your VD, which is your physiological dead space, and that's how you get it. Next thing is about very high yield is about lung and chest wall properties. So because of the historical reasons and small pressure, pulmonary pressures are always presented in H2O. Okay, great. Elastic, three things. Chest wall properties, looking at three things: compliance, elastic recoil, and hysteresis. Okay, so what do we have? We have elastic recoil. What is elastic recoil? Well, it's the tendency for lungs to collapse inward and the chest wall to spring outward. So if I draw a lung here, I mean, I'm bad at drawing, guys, but bear with me here. Okay, so if this is a lung, let's say, and you have a a chest wall. Let's say this is a chest wall. So the lung is trying to pull in all the time because of elastic recoil, and the chest, because it's all the muscle, it wants to pull out. It wants to spring outwards, right? So there is a pressure developed just by, this opposite forces contributing to each other. So that pressure, what is it going to cause? So it's going to these two things. This inward and this outward and inward pressure would lead to, which cancel each other out, right? And it will form it's called alveolar pressure of 0. It's going to form alveolar. At this point here, alveolar pressure is going to be 0. And guess what? When we're sitting in a normal room, at a room, there is no, it's a normal air outside. What's going to happen is, what is the pressure outside in the air? 0. Yeah? You have alveolar at the 0, outside pressure is 0. That's how you can breathe in that air, right? So it forms because, and why this all occurred, because this inward force is cancelled out by this outward force, and it forms the alveolar pressure 0, forming the alveolar pressure of 0, which is equal to the atmospheric pressure, which is also 0. So the air is now coming in. Air can come in and go out at your FRC. And what is FRC? Let's read this. At FRC, airway and alveolar pressure equal the atmospheric pressure, which is PB 0. And intrapleural pressure is negative. What is intrapleural pressure? This is it. Oh, what did I do? Uh-oh. I have to draw this again now. Wow. Okay, yeah. Let me just do this again quickly. Okay, let's just do it this way. Okay. Okay, now let's talk about what is intrapleural pressure right here. Intrapleural pressure of negative. So it's saying right here, intrapleural pressure is negative, preventing atelectasis. The inward pull of the lung is balanced by the outward pull of the chest wall. Systemic pressure is atmospheric, again, which in other means saying 0. Pulmonary vascular resistance is at minimum, for sure, 100%. So now look at this graph on the right side picture. So important point is, this is your rest, or call it FRC, which is rest basically. So at your FRC, or the rest, your alveolar pressure is 0, but your intrapleural pressure is -5, high yield, -5. Intrapleural pressure, -5. And as you breathe in, it's going to go up to -9 and then drop back to -5. Well, the alveolar pressure is at 0. It starts at rest, which is at 0. Look at the lung volume, it is 0, that's it. That's why I'm saying it's at rest. And what is at rest? It is at FRC, and you have alveolar pressure of 0, but intrapleural pressure is -5. Why? Because these two negative forces made a negative pressure within the intrapleural space, making it -5. No rocket science about it. Okay, that's all for this elastic recoil. Looking at the compliance now. Let me change color. Compliance is your change in lung volume for a change in pressure. So change in volume divided by change in pressure, inversely proportional to the wall stiffness, and increased by surfactant. Okay. Increase in compliance will lead to lung easier to fill. Again, compliance was your distendability or stretchiness. How how much a lung can distend, or your stretchiness, how much a lung can stretch. That's same thing as calling compliance. So that stretchiness, when you increase the stretch of a lung, it's easier to fill. Example, emphysema and high yield older adults. What's going to happen to your how do you decrease in compliance? Well, decreasing in compliance, lung would have more difficult to fill, and it is seen in your fibrosis, the pneumonia, the RDS, the edema, right? and that's pretty much all. The last one is hysteresis, meaning lung inflation follows a different pressure volume curve than the lung deflation. And what is that curve? So basically, lung inflation, expiration is a normal shape, sort of a curve, but the inspiration is not so normal, but they all equal. My bad, they have to equal. Okay, let's do it here. So this is your inspiration, expiration, and this is called hysteresis, meaning lung inflation curve follows a different pressure volume curve, which is right here, than the deflation, which is a different pressure curve. Why did that happen? To overcome surface tension in forces in inflation. Important picture is on the right side as well. What do you have? You have FRC. If you look at FRC, is right there. Basically, what is FRC? It is at rest, the resting lung, meaning it has nothing. There is no pressure in the lung, and that is FRC. So in emphysema, FRC is increased, and in your fibrosis, emphysema, the other way you can think about emphysema is as your restrictive and your obstructive lung diseases. So obstructive lung disease, you have FRC increase. Your fibrosis, your restricted lung disease, you have fibrosis, which is FRC is decreased. And the normal is your lung, chest, wall system. Net compliance is your normal curve. Okay, yeah, that's all for this page. Let's move on with the next one. Pulmonary circulation. Okay, pulmonary circulation. So normally, it's a low resistance, high compliance system. A decreases in PaO2 causes hypoxic constriction. Okay, PaO2 causes hypoxic. If you decrease in PaO2, which is pressure in the alveoli, O2 pressure in the alveoli, it causes vasoconstriction that will shift. This is very high yield. So if you don't have oxygen, it's going to cause vasoconstriction. This is only occurring in the lungs. The worst is in your body. What's going to happen if you have a low O2 everywhere except the lungs? If you have a low O2, it's going to cause vasodilation. Only in the lungs, in hypoxia, your low O2 is going to cause vasoconstriction. That's going to shift the blood away from the poorly ventilated regions of the lung to the well ventilated region of the lungs. Perfusion limited. Now there are two things now. What is perfusion limited? Perfusion limited means that you have O2, normal health, O2, and CO2, carbon dioxide, and nitric oxide, N2O. These gases will equilibrate early along the length of the capillary. If you look in this image on the right side, what do we have? Looking at your perfusion limitation, look at your PaO2 right away. Look at this. Let me just draw this. Look at this. PaO2, PCO2 right away. They will equilibrate early along the length of the capillary. Okay, so exchanges. So how would you increase the exchange? Because right away it reached that 100% mark. You can't go beyond that. So the only way to exchange is you have to increase the blood flow. So perfusion limited, in other words, in perfusion limited, the gases would equilibrate early, and the partial pressure of the gas in the arterial blood becomes equal to the partial pressure of the alveolar air. So in order to increase the perfusion limitation, you would have to increase the blood flow. While in a difference between this versus the other one, which is your diffusion limited, it is your O2 in your diseased state like emphysema, fibrosis, and carbon monoxide. The gas does not equilibrate by the time blood reaches the end of the capillary. It is limited. It is diffusion limited. It is limited. Again, if you look at, let me go this way. Look at the name: perfusion limited, diffusion limited. Perfusion, you need more blood flow to increase perfusion limited. Diffusion limited, you would need what? you would need to gas does not equilibrate, right? So you would have to increase. So let's read actually diffusion limited before I say these things, and you will not understand. So let's read the whole thing. So O2 diffuses slowly, while CO2 diffuses very rapidly across the alveolar membranes. Disease state that lead to diffusion limitations are pulmonary fibrosis. So what's going to happen in pulmonary fibrosis? Now let's talk about it. So in pulmonary fibrosis, in normal healthy patient, what's going to happen is, as you know, that in normal healthy patient, all you have is, let me do this. So in normal healthy patient, you're not going to have diffusion limitation. Why? Because if you look at O2, it's seen only in emphysema, fibrosis, and carbon monoxide. In normal healthy patient, you will just see in your perfusion limitation. But one of the things normally you will see diffusion limitation is exercise. So why would you have diffusion limitation in exercise? Why? Because your pulmonary blood flow is so much increased in exercise that the air is getting shorter. In a healthy individual, it acts as a perfusion limitation, but in patient with already diffusion limitation, for example, you are exercising and you're in diffusion limitation, what's going to happen is, if you exercise, let's say if you have disease, let's say emphysema or obstructive lung disease, anything, and you exercise, what's going to happen is, exercise can cause increase in blood flow, pulmonary blood flow for sure, 100%. But that blood is not going to get oxygenated by the time it reaches the end of the capillary, and it causes hypoxemia, which is decrease in PaO2 low after exercise. So again, let me summarize this point for you. So diffusion limitation does not occur normally, but in exercise, what's going to happen is you're increasing the blood flow, especially where the people who already have the disease, who already are diseased. What's going to happen, like disease, for example, if you're in obstructive lung disease or your restricted lung disease, what's going to happen is with exercise, you're going to increase the blood flow so much, but because of that disease, you cannot get the air there. So when you cannot get the air there, you're not going to have this alveolar. You're not going to have this. There's going to be mismatch, meaning the oxygen is not there, but the blood is there. So there's going to be a mismatch. It's called hypoxemia. Is going to occur right after exercise in disease patients. So this is all about this. But looking at a picture here, very high yield. If you look at this diffusion limited, same oxygen with the diffusion limited, it's just trying to reach 100% level, but it's not, because there's a limitation. There's a diffusion limitation. Why? Because there's a fibrosis. The air, the blood is there, but the air cannot get into the blood because there is diffusion limitation. Basically, if this is alveoli and this is blood, there's diffusion limitation. There is fibrosis here, so air cannot go into the blood. These are RBCs here. Okay, so this is what we have in diffusion limitation. And for CO2, carbon monoxide, it follows diffusion limitation curve. This is also high yield, and we will see that how in the coming pages of CO2. What else we might have? What else? Okay, yeah, one more thing about this point here, high yield point. And the factoid is when you have vasoconstriction. Why would you have vasoconstriction? Because of low O2 is going to cause vasoconstriction, right? That vasoconstriction in lungs is going to cause increase in pulmonary artery pressure. That increased pulmonary artery pressure can lead to cor pulmonale. High yield and maybe concept, okay. Although very simple, but high yield. Okay, on the right side, what do we have? It causes chronic hypoconstriction. Now it's saying this was, it is chronic. Same thing, almost same thing. Chronic hypoxic vasoconstriction, same thing. Pulmonary hypertension, cor pulmonale. This is very high yield. Diffusion, if you want to read it, you could, but it's there. But DLCO is important. What is DLCO? DLCO is diffusion capacity of carbon monoxide. Carbon monoxide. This measures the ability of the lung to transfer gas to the RBCs. So what is DLCO? It measures the ability of the lung to transfer gas to RBC, right? This is DLCO. Again, what is DLCO? It is a diffusion capacity of carbon monoxide. It is the extent to which CO passes from the air sacs into the blood. So here's the air sac, and here is the septate, and here's the blood. So this is DLCO. Okay, so what do we have about DLCO? Let me look at this now. Yeah. Okay, now one last point in this discussion is all about your we talked about that one. Okay, great. Yeah, the one thing is DLCO is going to be increasing your asthma state. DLCO is increased in the asthma. That's important. And it is decreased in almost all the other diseases like urine emphysema, pulmonary hypertension, pulmonary embolism, or interstitial lung disease, anything. So most of the diseases have low. There's going to be decrease in DLCO, but only one disease which has increased as of right now is going to be asthma, and that's all. Let's look at pulmonary vascular resistance. Pulmonary vascular resistance. What do we have here? Again, it's a bunch of formulas in there. You can, if you need explanation on this, I mean, I could explain you more. But if you need it, let me know. I'll explain it in the comments. Because there's nothing much here, not much here. Moving on with the alveolar. Ventilation perfusion, very high yield. Ventilation perfusion mismatch, very high yield topic. Ideally, let me read this. Okay. Ideally, the ventilation V is mismatched to perfusion Q per minute. So VQ equal 1. My bad. V is matched, not mismatched. It is matched to perfusion, which should equal ideally to 1 for adequate gas exchange. But lung zones, for example, the upper zone, the apex, the base, the apex has a VQ of 3, while the base has VQ of 0.6. So you have wasted ventilation in the apex, and you have wasted perfusion in the base. And you say, how? How is that? So because we said ventilation is divided by perfusion, in the apex, what you have is, if you look at this picture right here, what you have is you have low ventilation, but you have way too low perfusion, meaning way too low blood supply, but sort of a low ventilation, meaning air is also going there, but to a lower amount. That's gonna lead to overall increase in your VQ, and that's gonna cause equals 3 highest VQ. And here you would say we call it, basically it's here wasted ventilation. This ventilation is wasted. Okay, now looking at the very last zone, which is the base. So this is apex and this is base. Here we have increase in your ventilation, and you have way too much perfusion there, too much blood supply there. So it's going to cause decrease in VQ, right? And that's how you're going to get 0.6. And that's just wasted perfusion. Wasted. And over there was wasted ventilation. The perfect is the zone 2, which is your VQ is approximately 1. And that's the perfect. So just got to rote memorize somehow that the apex has wasted ventilation and the base has wasted perfusion. Actually, Q is perfusion, yes. And the this middle zone is is perfect. Zone 2 is perfect, almost perfect, because it has matched. This is ideal situation. Okay, let's look at the next line, which says, let me change color. Okay, both ventilation perfusion are greater at the base and of the lung than at the apex of the lung. With exercise, you have increased cardiac output. There is a vasodilation of the apical capillaries, causing VQ ratio approaches 1. Certain organisms that thrive in high O2 or tuberculosis, they flourish in the apex, high yield. Tuberculosis, they flourish in the apex. But again, tuberculosis, when they're reactivated, they go back to the apex. First infection occurs at the lower lobes of that of the lung. Okay, VQ, now high yield this point. VQ equals 0 when there is an airway obstruction. VQ equals infinity when there is a blood flow obstruction. High yield. So how do we get to this level? VQ equals 0 airway obstruction. If you go back to the formula again, there is airway obstruction. That means there is a 0 ventilation, but the perfusion is still there. Let's call it a 3, let's say, or a 1, whatever you call it, and this should equal 0. Ventilation is now 0. Ventilation is now 0, and 1 divided by 0 is going to give you infinity. Or you can call it 3 or 1, same thing, doesn't matter. But this is important, that if you have an airway obstruction, you have a ventilation perfusion mismatch, 0 to a level of 0. There is no gas exchange. But if you have a blood flow obstruction, there is a infinity. It's a physiological dead space. That means air is coming in, but there is no blood to take that oxygen in, and that airway obstruction is called shunt. Basically 100% shunt is there. So in shunt, 100% O2 does not improve with the PaO2, foreign body aspiration, while VQ to infinity, blood flow obstruction, physiologic dead space, assuming less than 100 dead space, 100% of O2 improves PaO2. So again, there should be a table here. 100% O2 does not improve this airway obstruction, but it does improve blood flow obstruction. Alveolar gas exchange, again, this is all about formula. If you want to know more about me, this is just reading part and understanding and memorizing sort of a thing. But the important thing is your AA gradient, and that's important. What is AA gradient? The big A and small a gradient, right? The big A is your alveolar O2, and the small a is your arterial O2. Normal AA gradient estimate about age divided by 4. Age divided by 4 plus 4. For example, if a patient is less than 40 years old, the gradient should be less than 14. So normal AA gradient is less than 14. Okay, so